Good afternoon, everybody. My topic is about infection control in heart rhythm devices. As you are aware, many patients require these devices, whether pacemakers or ICD or defibrillator. Pacemakers are implanted in patients who have slow heart rhythm, and implantable defibrillator is implanted in patients who have tendency for malignant arrhythmias, which can cause sudden cardiac death. And there is a third device, which is CRT, which is basically given for heart failure patients, a small subset of heart failure patients who have conduction disorders. So these are the heart rhythm disorders typically that we talk about. Now, most of the patients, they remain very well and they improve with device therapy, but some of them, a small fraction, maybe 1 to 4%, can develop infection. And that can be a very devastating problem for the patient because it is very difficult to treat. Once it develops, we often have to remove the device completely, which is again a very complex process, and then implant a totally new device. These devices are very expensive besides the trouble that the patient undergoes during implantation or explantation. The devices, it adds to the burden to any organization or to the patient. One of the reasons why explantation is very difficult is that, as you can see, there is formation of fibrosis around the leads inside the heart and vasculature. So they become very difficult to remove after a couple of years. And if infection develops, then we have to remove them either surgically or through some special instruments. But that both processes are complex and cause significant morbidity and mortality to the patients. Now, as this particular slide shows, the incidence of infection is about 1 to 4%, but about 20 to 50% may be susceptible to infection, more vulnerable compared to others. And it is our job to identify those patients and see what we can do for these particular patients. Now, one of the risk factors is prior procedure. So if the patient has already had a pacemaker or ICD or CRT implant and is undergoing for replacement, then the risk of infection is significantly higher. And as the right panel shows, the number of prior procedures correlates very well with the rates of infection. So that is one factor which you have to keep in mind. Other factors which are frequently seen which make one susceptible to infection are like type 2 diabetes, chronic kidney disease, airway disease, obesity, other like heart failure, etc. And of course malignancy. And if patient is on immunosuppressive therapy, then that makes a special vulnerability for infections. And of course patients who are on dialysis, they are more vulnerable definitely. Now this slide shows that the number of infections has risen faster than the number of implants. So for example, from 93 onwards, if the implants have grown by nearly 100%, the infections have grown by 200%. And this is because now the mix of devices and the patients has changed significantly. Now many very old patients are getting devices and number of comorbidities is higher. The procedures are longer because devices are more complex, particularly defibrillators or CRT devices, they are complex devices, and many patients are undergoing revision from previous implants. So all that adds to the risk of infection. So as I pointed out, the risk of infection is rising faster than the device implant numbers themselves. And as I said, once the device infection develops, we have to remove everything, all hardware, which is a very complex and dangerous process for the patient, and give sustained antibiotic therapy for a couple of weeks, sometimes 6 to 8 weeks also, and then reimplant a new device on the alternate side. We should not implant the same device, sterilize it and implant on the other side, because that side will also get infected quite often, and then we are left with no choice. So we should preferably use a new device. Now this slide basically shows the mortality trends with and without infection. So as we can see, patients who get CIED infection, they have a much higher mortality compared to those who don't get infection. And these are typical preventive therapies that we have been using conventionally. We give pre-operative antibiotic 1 hour before the procedure. We give peri-operative measures like pocket irrigation with antibiotics. And most people like to give post-operative antibiotics also. Our practice is also to give 48 hours of intravenous and then 3 to 5 days of oral antibiotic. So that is how we try to prevent it. But even then, some patients can develop infection. So this is some new technology that I want to talk about. This is a absorbable antibacterial envelope, which has been in use for last few years. And this is basically made from absorbable multifilament mesh, which delivers antibiotics locally for several days. Because when you inject at the time of implantation, if you inject antibiotic, it will be there in the pocket for maybe a few hours and then get absorbed or utilized. But this can continue to release antibiotic for up to 7 to 9 days. And it gets absorbed completely after maybe up to 8 to 9 weeks, it is completely absorbed. So that's how it looks like immediately after implantation. It surrounds the device and it is there in the pocket. It will keep on releasing antibiotic for 7 days and gradually get absorbed by dissolving into fragments, and then it gets fully absorbed. So at the time of re-surgery, it will not impact the procedure at all. And this is the graph showing how it delivers a sustained level of inhibitory concentration of antibiotics for up to 7 to 10 days. And the antibiotic it contains is minocycline and rifampin, which cover up to more than 70% of all common infection organisms that we encounter. As far as evidence is concerned, this is a large study called RAPID study, which was published in New England Journal, where they assigned about 7,000 patients. It is a very large study, underwent randomization, about 3,500 to receive the envelope and 3,500 without envelope. And they followed them for 12 months. And they found that the incidence of infection was reduced by about 40%. So the risk-hazard ratio was reduced to 0.6 in this particular study. And it affected both pocket infections and systemic infection. And this is a long-term follow-up study where they found that the benefit of infection control is sustained by this particular antibiotic envelope called Tyrex. And there was no system of procedure-related complications because of the envelope. So on the basis of this large study, it was found that the risk of CID infection is particularly high in patients who have CRTD implant or who have a second or third procedure. And it is highest in patients who have both these factors, like they have a bigger device like ICD or CRTD, and it's a reimplant, and patient is also on some immunotherapy or dialysis, or patient has had recent infection. So these are the patients with highest risk, and obviously the benefit is also highest. First time pacemaker implant carries a lower risk comparatively. So this is the last slide, which basically relates to how we can assess the risk of infection in a particular patient. So, of course, as experts, as we people who are implanting these devices, we have our own complicated algorithms, but every doctor can understand few situations where risk of infection will be higher. So, as I said, a more complex device, whether it is ICD or CRTD or CRT, because of long procedure time, the risk of infection is higher. Then patients who have either renal failure or who have malignancy and are on immunosuppressive therapy, who are diabetics, who have other comorbidities like pulmonary COPD, etc., and heart failure. So these are patients with comorbidity, they have a high chance of infection. So at least in these patients, we should try to utilize this antimicrobial envelope. So I think I will stop here. If there is any question, I'll be most happy to answer. Thank you so much. Any questions?
Sir, in spite of giving the antibiotics,
Mike?
reasons for such type of infection.
So infections can develop either acutely or later in the course of this thing. So we are talking of, because later is like any bacteremia. if the patient undergoes a tooth extraction or some genitourinary procedure or any other surgery, bacteremia can settle on the leads and can cause infection. That's a late infection. But acute infections are generally because of inoculation at the time of implantation, which can happen through air, it can happen through some contaminated saline, some gauze piece or something, because in every hospital we try to make best possible sterilization. But as we know that nothing in life is perfect, and we make every effort, but still one odd patient can get infection. So the incidence may vary, say maybe 1% in a good place, or maybe 2% in a not very good place, 3% in a still, if one is not careful, the hospital is not very careful. But every hospital is careful. So it depends on the processes, it depends on the people who are employed there, how stringently they sterilize all these things. But as a policy, every hospital tries to do their best. I would request, both my chairpersons are very renowned and experts in device therapy, so we will listen to their comments.
So this envelope that we have, so is there any size specificity, or it is for every device?
Yeah, so there are two sizes available. Earlier only one size available, now a smaller size is also available for pacemakers. But it can be, and then extra size can be just wrapped around the device or folded and put in the pocket. The pocket needs to be slightly larger compared to otherwise, and because it also, besides the increased bulk, it offers some resistance because of the mesh itself. The pacemaker surface is very thin, it slips in even in a tighter pocket, but this one requires a little bit extra pocket, size of pocket.
Do you think particularly the infections, have you observed after 8 to 10 days?
Yes, so that's what I was talking. Acute infections typically manifest as discharge from the suture line, which may be either very superficial, which is also quite often seen, and sometimes it is in the pocket where there is discharge more copious, and when we press the pocket, then there is further discharge. So then we know that discharge is coming from the pocket. But many patients have superficial infection because of sweat, ingress of sweat in the suture line. And one thing that we take care is that the deep closure of the deeper layer has to be as tight as possible, because that prevents ingress of any material into the pocket itself or contamination of pocket. So we make every effort to prevent infection, but infections can happen sometimes.
And since how many days you are using these envelopes?
So for last, I think 2 years or so.
2 years.
Yeah.
But are they used all over country?
Yes, they are used all over country.
I think you've already pointed out the most important things. One thing I would like to say here is that especially for the physicians, because many times patients would get an implant here, then go back and be showing in their own clinics, is that if there is a kind of a stitch infection which is very superficial, as Dr. Anil said, that is fine, one can manage. The moment you have pus coming out of the pocket, one cannot hope to cure it by antibiotics. It has to, the foreign thing inside the body has to come out. People keep on hoping against hope, keep on giving antibiotics. It dries up, then comes again, then dries up, then comes again. No point of going, it has to come out. And the earlier you go in, the easier it is for it to come out. Otherwise,
It adds to the cost and frustration of the
cost
patient.
and the frustration, and the antibiotics have their own side effect. We've seen renal failure in these patients, severe anemia. So, and then once these patients do go in for this thing, I think the cost should have an inbuilt for the, because even though this is not 100% effective, but 40% reduction in infection is a very significant amount for these patients who have had a very bad time, a lot of disfiguration and everything.
Are these Tyrex for corporate, especially since we are in a meeting with corporates, do the corporate allow this Tyrex envelope?
Yes, some of them allow. Yeah.
So you have to specify.
One has to submit an estimate, and they may at their discretion at that point of time, because things keep changing in the corporates also. Sometimes they are short of funds, sometimes they are more funds, more liberal, less liberal, and the person who is judging it. So sometimes we have seen that they are approved, sometimes they are not approved.
Many times actually you can get a corporate buffer, right?
Buffer, exactly.
So it should cover it.
Yeah.
Any other question?
Yes, please. It has been hacked. Yeah, that's not possible now at the moment, because first of all, we cannot program the pace. They're very, they have a built-in safety mechanism that they cannot be hacked by any other device. The only communication was with the programmer. They have a specific code that communicates with the programmer. Now we have pacemakers that have Bluetooth connectivity, which can connect through your cell phone, and but they can only read the information. They cannot program the pacemaker. So there are enough safety mechanisms built into the device that one cannot hack the pacemakers at the moment. But once the efforts are being made to have more connectivity of the device with the cell phone and with other things, then we don't know what happens in future. But of course, this will be implemented only after having a very robust mechanism to prevent hacking. No, one cannot, because there is a specific code involved for that. Every device has a code and has a serial number. So it can be connected only once, and that also connection will be done by the industry people, and then nobody else can connect with the computer with that particular device. And as I said, as of now, we can only read the device information for any malfunction. We cannot program it or change any parameters to harm the patient or benefit the patient.
To reiterate, what he is saying is that you can make out what is wrong with the pacemaker, but as like in movies they show that somebody's pacemaker can be stopped.
You cannot stop it.
So you cannot make the pacemaker do anything as per your need. You can only diagnose what is the problem if there is a problem with the pacemaker.
You cannot change the behavior.
Change something inside it. It's not possible as of right now.
It is because, you see, till now we have been monitoring patients in the clinic. When the patient comes after 6 months or 8 months or 1 year, then we check the pacemaker with the programmer or ICT with the programmer and see what's wrong with it, if there is anything wrong with it. But like any electronic equipment, even if 1 in a million, there can be some problem in between also, which may go undetected for several months. In the meantime, patient may have complication, may be harmed. So this device, the Bluetooth connectivity, keeps on monitoring it on daily basis. If there is any malfunction, it can immediately alert. So the physician will get the alert that this particular patient, pacemaker, has this particular problem, and then hospital can get in touch with that patient and sort out the problem before anything serious develops. And this has been shown in the studies to actually improve survival of patients, that problems were detected early and patients were helped. So this remote monitoring is now a standard of care in the West, and in most, at least 20-30% patients are now getting remote care in our country also. So that is a pretty much standard now. But as I said, you can only diagnose the problem. You cannot change anything in the pacemaker.
So nowadays people changing whole life. We are changing clothes. So how you will every time you will manage?
It is not very common, as you're saying. It is not, it doesn't happen. It may happen 1 in thousands or 1 in lakhs or 1 in million, but complications like any electronic device can occasionally, rarely have malfunction, so which can be detected early. And the other question is that we don't have the choice. If there is a problem, we have to find a solution. And every solution cannot be 100% perfect. So even if it is 98% perfect, 99% perfect, in our lives also we make choices which are not 100% correct. But not making choice is not an option. So not putting a device is not an option because it is essential for survival. We can't have 100% not surviving because we don't want 0.1% failure.